Perfect Refractive Solutions. And to start off the proceedings, we have none other than Dr. Atishwar Das, who will be talking about the wonderful new trifocal lens from Care Group called the Triphobic. Please, sir.
Thank you, Shreyas. Good afternoon, everyone. I'm going to share here my experience with triphobic trifocal and the newly introduced Acrovision trifocal. It's just an analysis and outcome of this toric trifocal implants and extended range of vision implants over 1 year study, which I conducted in our center. Of course, this is my financial disclosure. So, to compare the visual acuity, the aim of the study was to compare the visual quality outcome of patients who had undergone bilateral trifocal diffractive IOLs and extended depth of IOL implant in their eyes. Around 50 patients were chosen. It was done by a single center and by a single surgeon. So these are the lenses we compared, which include the Physiol trifocal, which is a hydrophilic aspheric trifocal, the Zeiss 80 Lisa trifocal hydrophilic and trifocal with plate haptic, the triphobic and the Acrovision trifocal, which is cast molded hydrophobic intraocular lens, and the Symphony, the extended range of vision lens from USA. And we also opted for toric trifocal and triphobic, AT Lisa trifocal, and Symphony. I think Physiol doesn't have toric trifocal as yet in the armamentarium. So all the patients had undergone uneventful bilateral cataract surgery. We had done the optical biometer with LensStar Pro with TK values, which are verified, and we also used Barrett's TrueK formula. All the patients underwent cataract surgery with Alcon Centurion or a Alcon Legion phacoemulsification with a 2.2 clear tunnel. So the preoperative, we did an exhaustive workup looking at the tear film analysis, including the Mabo graph, and also we did the angle alpha and angle kappa value measurements. Contrast sensitivity was recorded using the LCD digital screen, and intermediate near visual acuity pre-op was recorded using the Colin Brandes chart, which I'll show you later. We excluded patients who had any history of glaucoma, macular pathology, any history of prior refractive surgery, preoperative astigmatism, which was more than 0.75, around 1 diopter cylinder. We went for a toric trifocal or a toric ERV. Patients with large angle kappa were excluded. Mu or chord value more than 0.6 were excluded from this. So these four IOLs were compared: the Physiol, Zeiss, the Technics Symphony, and the triphobic trifocal from Care Group. This is just a brief differentiation, the pros and cons of each lens. What's interesting to know here, if you could pay attention, the triphobic transmits up to 92% of the light incident. So the amount of glare and halos theoretically is less compared to the other trifocals, including the PanOptix, which does almost 88% light transmission. And the different technology available in these lenses, I'll just summarize brief for want of time. I have to run through. You see, in bifocal diffractive apodized is the Restore, whereas the PanOptic is trifocal diffractive non-apodized with Enlighten technology, and Physiol is a trifocal diffractive apodized, and the AT Lisa is trifocal diffractive non-apodized. Whereas the triphobic, the uniqueness of this design is this increased angulation or the slope height and decreasing height from the center to periphery. It's their patented design. I think they should give a name to it. It's apodization with increasing angulation. So this creates more amount of light transmission and less amount of glare and halos. This unique pattern of the triphobic trifocal definitely contributes to better visual acuity outcomes and less amount of glare and halos. This is the triphobic defocus curve. This was shared to me by the company. So I'll share our study results later. Here you could see the defocus curve is patients do tolerate up to 3.5 diopters minus and around zero point 0.5 in the plus side. The contrast sensitivity light distribution, again, you can see triphobic transmits up to 80% to 92% of the light transmitted. So amount of glare and halos is considerably less. I'll just show you a brief video of a patient who underwent toric trifocal had against the rule astigmatism of 1.575 diopter cylinder. I went ahead with a T2.5 as per their calculator. We also always cross check with the Barrett's 2K online calculator. Here I mark the patients preoperatively on the slit lamp, and this marking bisects the circular rexus. You have to aim for a centered circular rexus around 1.5, and I think you can achieve them without a femto as well. So this patient underwent microincision cataract surgery with Centurion phacoemulsifier, and here you can see, I'll just scrub through it. So the patient had this lens implanted, and the orientation of this triphobic toric was at 11 degrees. The uniqueness of this design again is the Takenes technology. You could feel the lens is very sticky. The haptics normally stick to each other when you implant them. And with the Acrovision trifocal, we have the Medicel injector, which is much smoother and easier to implant. It just glides through. So this patient had 6.6 N6 postoperatively on the second post-op day. This is another case which Acrovision trifocal. I'll just run through. These patients are undergoing presbyopic lens exchange. They want, as they desire to be spectacle independent. So Acrovision trifocal definitely improves the near and intermediate visual acuity with comparatively less incidence of glare and halos. So these are the other images of the lens, videos of the lenses we had implanted. The Physiol goes through a 2.8, it's slightly larger optic. It's around 6.25 mm optic. It goes through a larger 2.8 mm incision. The triphobic comfortably fits in through a 2.2 mm, and the Synergy again comfortably goes through a wound-assisted 2.2 mm lens. The Synergy comes with a screw-type platinum unfolder, so it requires certain amount of skill to insert the intraocular lens compared to the Medicel cartridge given by Care Group. So the results, around 22 eyes, 11 male patients and 28 eyes of female patients were compared. We recorded the distant visual acuity at the LCD chart, and we also converted to logMAR, and we used the Colin-Brander near intermediate and near vision chart. So this is the conversion scale for logMAR. So the results which said that distance visual acuity at the end of 1 week, 1 month, 3 months, and 6 months were almost similar for all the three classes of the lens. Here you could see the triphobic also achieving 6.6 unaided, 6 by 7.5 unaided, end of 1 week, and which was sustained to at 3 and 6 months. So distance with ETJR's chart also we compared, and we saw the triphobic excelled in all the 3 months. Up to 3 months, the visual acuity improved in triphobic, and it stabilized at 6 months and 12 months subsequently. This is the Colin-Brander intermediate visual chart at 63 centimeter, which we used to measure the intermediate visual acuity. So at 63 centimeters and 40 centimeters, when you use the Colin-Brander chart, again, initially the 1 week with uniocular implant, patients were reading up to 20 by 25 for near, then it improved to 20 by 20 with binocular implant at the end of 1 month and 3rd month, and it sustained to the 6th month. This is a 100 centimeter chart of Colin-Brander, which is again, the size is calibrated according to the distance where you measure. We had a similar results with triphobic here as well. Once you implant them bilaterally, we normally take 1 week gap between each eye to undergo this trifocal implants. Once you implant them bilaterally, they did have N6 or 20 by 20 near vision Colin-Brander chart at end of 1 month, 3 months, and 6 months. So these are the Bartle images which are given by these Alcon people, and I think it varies for which company you borrow these images from. Each one of them justify that they have optimal clarity at near and intermediate. However, I feel that the Indian indigenously produced hydrophobic, triphobic acrylic, which I've been implanting over the last 4 years, is also giving excellent outcome. So this is the post-operative pictures taken at 6 months. You could see Zeiss 80 Lisa Tri. We did have some patients with PCO because of the tri-hydrophilic platform, and we had to YAG them. The YAG rates are much lesser in the hydrophobic platform. So coming to summarize, an accurate, precise biometry is important. Do look at angle kappa and angle alpha preoperatively, and opt for a toric IOL if the astigmatism is more than 0.75 diopter cylinder. Aim for a central 5.5 to 5 mm rexus. In my preference in myope with presbyopia, I go with EDOF for a trifocal hybrid vision, trifocal in one eye, at fusion IOL in the other eye. And with a hyperope I always opt for a trifocal bilateral implantation. And another important point, do remove the OVD from behind the lens to avoid capsular bag distension syndrome, because these patients will opt for a fellow eye surgery within a 1 week, and you don't want to have any capsular bag distension syndrome causing a myopic shift so that they don't have good distance vision. So do have a complete OVD removal from behind the lens to avoid CBDS. So these are the results. I like to conclude saying that the subjective photic phenomenon, triphobic, was definitely less compared to Physiol and AT-LISA trifocal. It was definitely more than Symphony, which is an CRV lens. The PCO rates were again comparable to the hydrophobic lenses. The near and intermediate vision was also excellent with triphobic when compared to other trifocal, which is Zeiss AT-LISA tri and the Physiol. Thank you for your kind attention.
Thank you, sir, for the very comprehensive talk. I think very nicely summarized results. And I quite agree with this. We also did a study comparing triphobic with PanOptix, 40 eyes in each group. And the results were very, very similar. I think, like you said, both the toric as well as the non-toric platforms, results are very, very consistent.
And the glare and halos also, I think, patients, so they're able to read in low light. That is what's something surprising. And even they are not able to tell how the patients are able to read well in low and dim light with this trifocal implants. That's again a remarkable quality of these lenses. Thank you.
Thank you so much, sir. Thank you. Next, I'd like to invite Dr. Amit Pandey to talk about iStent, the Indian experience.
Good evening, everyone. So let me talk about the iStent, which has been a hot topic. Okay. I don't have any conflict of interests. We all know this. Glaucoma is the leading cause of irreversible blindness in the country as well as the worldwide. Huge numbers, 90% are undiagnosed, and even those who are diagnosed there are a lot of problems. They're not treated properly, or their adherence is a big issue. What we follow here in our country mainly is the stepladder kind of a pattern of glaucoma therapy, where vast majority of our patients are on medications, and when these patients advance into a more severe kind of a uncontrolled glaucoma, we usually do a trabeculectomy. When that fails, we do a tube. When everything fails, we do a cyclodestruction. But the problems with medical management is the biggest problem, I think, is the compliance issue, where almost majority of our patients don't adhere to their prescribed regimen. The problem worsens when the patients are on multiple medications. Ocular surface disorder is another problem. Systemic side effects. Poor quality of life is something that we don't usually think about, but it really affects our patients in a big way, with multiple drops daily, and dependence. Many of these patients are dependent on their family members for putting their drops. Fluctuations in the intraocular pressure with medications is another big issue. And we know the benefits of surgical management, where more stable IOP without medications, we can get lesser visual field loss, lesser adherence and compliance issues, lesser OSDs, and overall a better quality of life. But surgical options are limited. Before the advent of MIGS, the surgical options were limited to severe and advanced cases, because the risks of these filtration surgeries outweigh the benefits that we get in mild and moderate glaucomas. But MIGS is here to fill this gap between our medication patients and trabeculectomy patients very effectively and very safely. What is MIGS? MIGS is a minimally invasive or a microincision glaucoma surgery with a wide variety of implants, devices, and techniques to lower the intraocular pressure with a very less surgical risk. That's the main important differentiating factor of a MIGS from a more filtration surgery. In India, we have the iStent and the iStent Inject are the only implants that are available in India. We have the Trabectome, the KDB, the GAT of the Suture GAT, and Bang as well. So where are we going to do these surgeries? We can do the iStent in mild and moderate glaucomas, preferably undergoing cataract surgeries, especially open angle glaucoma, pseudoexfoliation, PDS. Patients who are on multiple medications, allergic to medications, who are contraindicated to medications, non-compliant, you know that the patient is not putting his drops properly, who comes late for follow-ups, so their relatives say that they are not putting their drops properly. One-eyed patients, again, where high risk of a trabeculectomy would outweigh the benefit, and high risk of hypotony related complications. One eye you have done a trab, patient has landed up with a hypotony related complication. The other eye, would you risk doing another trab? Here you can do a mix. Why mild and moderate glaucoma is only because the aqueous drainage is happening through the natural pathways, and the IOP reduction is limited to the physiological levels. What we are achieving is around 30% of maximum reduction in most of our cases. And in advanced and long-standing glaucoma, there is a feeling that the collector channels or the Schlemm's canal might have collapsed, and angle surgeries might not be helpful. But and contraindications to these surgeries would be angle closure with extensive 360-degree pass. Some people are opening up these pass and then doing an angle surgery. Secondary angle closure, I would definitely not do an angle surgery, especially a neovascular glaucoma or uveitic glaucoma. Patients with it related to increased episcleral venous pressures, where IOPs are extremely high, 50, 60 IOP, I'm not going to usually do a angle surgery. Severe advanced visual field loss is a question mark. In some cases, in some scenarios, we might do a mix. Angle recession, I've done in a few patients, and results are very encouraging. Pediatric glaucoma is again a question mark, because we have been traditionally doing sort of an angle surgery in these patients like goniotomy. And I think pediatric glaucomas would also benefit from an angle surgery. Special indications, post filtration surgeries, we have been doing MIGS now. Have almost 6 patients now with 5 patients with post TRAB and 1 patient post AGV as well, where I've injected, I've done a mix, mostly eye stents, where the IOP reduction required is not exorbitant. In those cases, instead of doing another filtration surgery and risking, this is a very good alternative that we have, because here the conjunctival scarring is irrelevant. Patients with scleral thinning and staphylomas, which bars any filtration surgery, congenital developmental glaucomas, like I told, angle surgeries can be helpful. And in angle closures, where we have an occludable angle, which would open up after a cataract surgery, this is a indication. To begin with, we need the correct gonio lens. I use the iPrism SX, and it works brilliantly. It's so lightweight, so easy to use. I can just keep it there without any support, and it will stay there. I usually give it a little support with a finger, but that's about it. The weight is so light that it's very, very easy to use. Let's look at a case, a middle-aged guy with a significant cataract, open angle glaucomas with mild visual field loss, allergic to brimonidine, and timolol is contraindicated because this patient is an asthmatic. What do we do? Traditionally, I would have done a phaco and then maintained him on the other medications, but we did an eye stent and a cataract for him. So the eye stent Gen 1, this is how it looks like. This is the retention arches that it has. This is the lumen. This part goes into the trabecular meshwork, and this part stays in the anterior chamber. It's so tiny, it's so small that it's one of the smallest devices to be implanted in the human body. It's made of a surgical grade non-ferromagnetic titanium. That means we can do an MRI in these patients if needed. And it's heparin coated to promote self-priming. It bypasses the trabecular meshwork, which is, as we know, the source of most of the resistance to the aqueous outflow. This is the injector, how it looks like. This is the surgical steps. It's very, very easy to implant. It's a 5-minute procedure, hardly takes 5 minutes once you get used to it. And you can see the visualization is very good with the iPrism SX. And there you go. You tap to see if it is in position. It's under very high magnification. A bit of blood would come out, which is a good sign. That means you are in position. And this is how the position looks like. And we usually implant it in the nasal or the inferonasal angle, where the maximum collector channels are. This is post-op day 1 with crystal clear cornea, 6/6 vision, IOP controlled. This is how it looks like on gonioscopy. This is the iStent Inject or the generation 2. It is completely different from the generation 1, and each injector has two implants in it, and both the implants would go in the same patient. This is how the injector looks like, and this is the surgical step. We retract the sleeves, target the trabecular meshwork, make a small dimple, visualization is the key. The en face view that you want with these surgeries, and you press the button. That's the first implant, and 2 clock hours inferiorly you go and place the second implant similarly. So iStent has 15 years of experience worldwide, more than 1 million implants worldwide, and 300 plus articles published with sustained IOP reduction shown by Dr. Richard Limstone. 4 years, 46% IOP reduction, 95% patients are medication free. And this is a systematic review and a meta-analysis of studies using iStent devices as a standalone procedure as well. These are 13 studies with 778 eyes and a follow-up period of ranging from 6 months to 5 years. And most of those studies are showing sustained intraocular pressure reduction as well as sustained reduction in the number of medications as well. Disease stability, visual field mean deviation from baseline, not much change. Combined with cataract surgery, again performing very well. RNFL defect, RNFL thickness in terms of follow-up periods, again very well stable. CD ratios stable. So disease stability is also very good with these surgeries. Quality of life outcomes were evaluated in this study, and excellent quality of life improvements are seen in this patient. The safety is the key. Safety of iStent is the most important point why we are going to implant these in our patients. My results, I got the inspiration of doing MIGS in the last AIOC conference, and in almost a year I've done 60 plus cases, and I've done 17 iStents with at least 2 months of follow-up, 11 iStent Gen 1, 6 iStent injects, and majority of these patients have been reimbursed partially or fully by the insurance companies. I've done 12 combined with cataract surgeries and 5 standalone, 2 combined with femto cataract, and 3 combined with a trifocal or a DDOF lens. Most of my patients are open angles. Have done in 3 angle closures as well, and like I told, 4 patients post trabeculectomy and 1 post VR and post AGV as well. So I'm seeing almost a 30% reduction in my patients with almost a 70% reduction in the number of AGMs. Comparing iStent with other MIGS procedures, the manual MIGS, this is truly a micro-invasive procedure with only 1% of the trabecular meshwork being involved. And TM is spared for the future interventions and medications in these mild to moderate glaucomas. We don't know what happens in long term to the trabecular meshwork when you rip open 360-degree of the trabecular meshwork, what happens in the scarring, what about these patients, how would they react to future AGMs that are targeted towards the trabecular meshwork. We don't know. So I prefer doing a truly minimally invasive surgery. And with a global experience of more than 1 million patients of the iStent platform versus very few data on the manual MIGS, the learning curve is very easy in iStent. It hardly takes a few minutes, whereas especially in suture CAD, it's a more difficult procedure. And post-op surgical management is also not as smooth as iStent, where a lot of patients end up with hyphemas and inflammation in the manual MIGS. And like I told, iStent has demonstrated to work even in trap failure patients. Cost is an issue, but majority of the insurance companies compensate for the implant, and we need to increase the demand, get more players involved, like what happened with anti-VEGFs in the retina. And my logic is, if we can ask a premium for a high cost IOL and femtocataract, why not for this vision saving device that can help save a lot of patients from losing their vision. My practice pattern is I discuss with the patient why we are planning a glaucoma surgery, and I explain the patient about the various surgical options that are available. Filtration surgery is usually required in a advanced damage and when intraocular pressures are very high, but the risks involved is also higher. So MIGS is a viable option in mild to moderate glaucomas to slow down the progression, to decrease the dependence on medications, improve the quality of life, decrease the need of more riskier filtration surgery in the future. And if insurance is covering the cost of the implant, I prefer doing the eye stent. If not, then other options are there. And the take home message here is MIGS is not an alternative to filtration surgery, and huge population of our mild to moderate glaucomas are progressing in spite of medical management, and MIGS can stop them from progressing into more severe form of glaucoma. It can prevent these majority of patients landing up with a trap or a tube in the future. And for the ophthalmologist, MIGS can do for glaucoma what anti-VEGF has done for retina. It will make glaucoma more lucrative part of ophthalmology. And for the young glaucomologist, it gives us a level playing field. Everyone is new at MIGS. Even a senior most surgeon is as inexperienced in doing MIGS as a young surgeon like me. iStent Inject is the only implant that's available in the country. It's the safest, time-tested, long-lasting, and easiest MIGS to do. MIGS has created a paradigm shift in the management of glaucoma worldwide, and it's high time that we practice it in India. These are the workshops that we did for MIGS, right from Glaucoma Society of India conference last year to AIOC midterm in Patna. We did a glauco skill development program in Center for Sight at Dwarka, as well as one workshop at Center for Sight in Hyderabad, which was very well received, and we are very happy with these workshops. And iStent has been a very versatile surgery for me. I've done a MIGS for a 10-year-old as well as for a 92-year-old patient also. Thank you so much.
Very nice talk, Dr. Amit. Very comprehensive talk. I wish there was a learned glaucoma panelist to ask you some nice questions. But nevertheless, how do you compare the IOP drop of iStent versus GAT or BANG procedures?
I'm seeing a more smoother IOP reduction with iStent. With BANG and in fact sometimes with KDB also, there is the initial inflammation in the eyes, especially with BANG hyphemas. I have had two patients who had very bad hyphemas. I had to intervene. I had to go and do an irrigation aspiration, and then the IOP started settling down. So it's much more smoother, much more easier to do, and I think it will be much more longer lasting than these excisional surgeries.
Great. Thank you. Thank you so much. Next, we'll move on to Mr. Doel Bishwas to talk on IPCL. Which was here? No. Maybe some of the care group staff can help and let us know who is available so that we can call them accordingly. Dr. Jatinder Wahi, Dr. Naveen Soni, Dr. Miguel Morcillo, Great. If others are not here, maybe just to cover up on Fakey IOL, Magnificent, anything from the audience, anything you'll want to discuss, anything which the care group team wants to highlight. Sending a presentation. Is he going to come? Okay. Sending a presentation may not be enough. Anyway, thank you. Thank you so much, everyone, for your time. I think since the other speakers are not here, we'll probably wind up now. Thank you.